The broadcast is now starting. All attendees are in listen-only mode.
It's showtime.
You know the day destroys the night, night divides the day. Try to run, try to hide, break on through to the other side. Break on through to the other side. Break on through to the other side, yeah. We chased our pleasures here, dug our treasures there. Can't you still recall the time we cried? Break on through to the other side. Break on through to the other side. I found an island in your arms, country in your eyes. Arms are changing, eyes are lying. Bring on through to the other side. Bring on through to the other side. Bring on through out. Oh, yeah! Plain to see, we go eat day to day, hour to hour. Day is straight, deep and wide. Bring on through to the other side. Bring on through to the other side. Bring on through, bring on through, bring on through, bring on through.
Wow. Those were the Doors at their very best, and I hope I can be my very best today also. This is Dr. Minarcik, and I have a big 52 on my cheat sheet here because it's our 50-second, 2-hour session in our free global online medical school pathology course. We missed St. Patrick's Day by 2 days, which was green, but today is red or orange. This is St. Joseph's Day. This is Tuesday, March 19th. It's 9 o'clock a.m. here in Chicago, and we're ready to rock and roll with some more medical school pathology. Today we'll actually be starting out with the big chapter on white blood cells, including lymphocytes and lymphoid organs in all their glory. I guess this is a pretty good time to do a test, which we always have to do. So you know what the first test question is. Did you hear me now, and do you hear the music well? Okay, good. Correct answer. Everybody got that one right. That was a bonus question. Second question is, what do you see on your screen? Okay, you got that one right also. We had this picture before, but it's my very, very favorite picture of the year. This is our group of, this is our base camp group of explorers at El Yunque Rainforest. These are your friends, the iguanas. There will be no Dr. August today. She let me know she's got some business, but that she'll be back on our next session. So you may not be able to get all your questions answered instantly today. Let's talk a little bit about the overview of what we're going to be doing. Believe it or not, I can sort of see the light at the end of the tunnel. We only have basically 4 more topics or chapters left. We're going to spend a couple of days on this big topic of white blood cell and lymphoid disorders, just like we spent the last couple of days talking about red blood cell and platelet and coagulation disorders. And then we have only one topic left for systemic path, and that will be lung diseases. And that's a big maybe 2 or probably more like a 3-session topic. And then we're going to go back to the general pathology topics that we missed. One of them was environmental nutritional disorders, and finally, at the very end, childhood or pediatric disorders. So we have 4 chapters left, and there'll be a couple labs thrown in there. So I suspect there will be about 9 or 10 more sessions until the end of the year. And the end of the year, this year, will probably occur just like it did last year, sometime in the middle or late May. Our last session last year was highlighted by my friend Dr. Kumar, who appeared with us and gave the graduation ceremony speech. I hope that all of you can be there for the graduation this year as well, because when I open up the webinar every day, I see a lot of familiar names. And I also wanted to remind you about Rock Lab. One of our students has already done Rock Lab, and he's here today. And it's a long, long journey. There's about 500 cases that you have to answer questions to, and then you send me the answers in any digital format that's the most comfortable to you. Then I look at it, then I call you for a 5-minute Skype interview, and then you have officially achieved the highest level of the medical school pathology course, and that is the privilege of earning my admiration in writing. Otherwise, I'm very happy to give everybody a certificate, and there are over 100 people that got certificates last semester as well. Okay, we might as well start with the topic now. I don't think I had anything else left to say, so let's talk about white blood cell disorders. And I guess here's a nice PowerPoint. Whoops, it looks like we lost it, so let's start it all over again. And as you can see, I don't think I ever registered this PowerPoint. In fact, it may be even pirated. So there's a big red line on the top telling me I'm going to go to jail. So I'll just keep my doors open for the software police and the internet Gestapo. Okay, here we go. And the screen's going to pop up telling me I'm a bad boy pretty soon, I think. Oh, maybe not. There we go. There's the bad boy tag. Well, we'll close it. We spent a couple of days talking about red cells and red cell disorders and the things that are related to them, like platelets and coagulation. And now we're going to move into the white cells. And not just the white cells, but, you know, one of the white cells, in fact, the second most common white cell in the body is the lymphocyte. So we'll be talking about lymphoid disorders too, things like lymphomas and such. So that's generally the title for the whole thing. We're going to go through a little recognition algorithm in a few seconds. I think most of you can recognize these, but we'll review them real quick anyway. This is the laundry list of topics that we'll be talking about. What are the things that cause either increased or decreases of various white cells? What are the lymphomas? How is a non-Hodgkin's different from a Hodgkin's lymphoma? What are the acute leukemias? What are the chronic leukemias? What are the lymphocytic leukemias versus the so-called myeloid leukemias, which is M1 through M7? And of course, myeloid is not just granulocytes, it's also things like red cell leukemias and platelet or megakaryocyte leukemias. We'll revisit the topic of myeloproliferative disorders. We've already talked about the P. vera as one of them when we were in the red chapter. Now that we're going into the white, we'll mention the 3 or 4 other ones as all being part of the same general process. Then we'll move on to the lymphocytes as they are in other organs, lymphoid organs like spleen and a few general disorders of thymus. That's the long laundry list, but I guess if you wanted to think a little bit more organized and briefly, you could think we'll be talking about normal white cell structure, function, kinetics, talking about lymphocyte and neutrophil disorders, the leukemias, the lymph nodes, and finally the non-hematologic lymphoid organs like spleen and thymus. Okay, let's go into a quick exercise here. I don't like to give you specific numbers, but you might kind of remember that about 2/3 of all the circulating white blood cells, and of course the cells that are nucleated in the peripheral smear, stained with right stain, are white blood cells. About 2/3 of these are what we call polys or PMNs. They have multiple lobes, usually more than 2, probably 3 or 4. Here's one with more than 4. You can see that one of the lobes has a little drumstick sort of pointing out. That is generally often regarded as the extra X chromosome, so you know that this blood smear was probably from a woman. Sometimes you could be fooled by another structure called a small club, but generally that looks like a pretty good drumstick to me. These are the precursors of the mature neutrophils. You don't normally see anything but mature neutrophils in the peripheral blood. When you see the cell called bands or stabs, in which the isthmus between the two lobes is as thick as the lobe itself, you normally see those only in the marrow, but whenever white cells are released for any kinetic reason from the bone marrow in large numbers as possibly a stimulus to infection or tissue necrosis, you see some bands or segs, or I'm sorry, bands or stabs, same thing, in the peripheral blood. Here's another band. I notice the scientists love to call these stabs, but most of the hematologists call them bands, and all of the hematology texts call them bands. You don't get to see the granules that well in this, but after the blast stage, starting with promyelocytes all the way to the mature neutrophils, you see these nice granules. They get more and more granular as they happen to increase. So as the white cells increase in the peripheral blood, generally as a response to infection, bacterial infection or necrosis, they generally get more granular as well. Here's another nice one. It doesn't look like it has a perfect bar body, but it might. These are the lymphocytes now in the second row. There's a larger lymphocyte possibly. It's hard to say because you can't really see the diameter of a red cell. But in here, whenever you see an almost perfectly round nucleated cell with often just a thin lip or rim of cytoplasm, and the nucleus looks like it's a couple of microns bigger than the diameter of an average red cell, that is a lymphocyte. That's your classic small lymphocyte. And remember, this distance of this diameter is generally pretty reliably 10 microns. This is the one cell in your body that is also the most sensitive to radiation damage as well. There's 3 lymphocytes. They may not be perfectly round, but they're almost round. And they often talk about the lip, LIP, of blue cytoplasm that you see around them too. Here's a couple of monocytes. If you think that the monocytes could be confused with the bands, you're absolutely right. They often are. Generally, though, the granules of the monocytes are not quite as granular as the granules of the cells in the neutrophilic series. Here is another cell, an eosinophil, and you can see that no matter how the stain is done, no matter how good, how bad, how lousy, the eosinophilic granules are always redder than the neutrophilic granules. And also, if you were to take away those granules, you could see that every eosinophil has only 2 lobes. And finally, we're down into the rarest of cells, less than 1%, the basophils. The granules of the basophils are so dark and so dense that they usually obstruct the view of the nucleus, cytoplasmic differentiation. So very often basophils are called lymphocytes unless you look at them pretty quickly. So we'll say these guys here are about 2/3. We'll say the lymphs are about 20%. We'll say the monocytes are less than 10. And the eos are only about 1 or 2, and the basophils. And those are all the normal white cells in the peripheral smear. Might as well talk about the most common one, and we'll talk about the neutrophils. Just like we said, the normal RBC count is about 5 million per cubic millimeter. the normal total WBC count, neutrophils and everything else, is about 1,000th, or maybe 1,000 to 1,500. So usually about 6 to 11 or 5 to 10 is a good general range. They're about 2/3 of the total normal, and only the mature neutrophils are in the peripheral blood. Sometimes the bands and maybe even a couple of metamyelocytes are, if there is a benign reactive process. But everything technically before the mature neutrophil is in the bone marrow. So the myeloblast is like any other blast. It's a big cell. It has no cytoplasmic differentiation whatsoever, no granules, and it has a nucleolus. The promyelocyte retains the nucleolus but starts to get granules. The myelocyte now has the more mature granules and loses most of its primitive, or what they call primary granules, like the promyelocytes have. Finally, the myelocyte is a cell that has a round nucleus. When that nucleus gets punched in, it looks like it's called a metamyelocyte. When it's punched in so much that the isthmus connecting the two lobes is about the same diameter as the lobe itself, that's called a band or a stab. And finally, in the mature neutrophils, there's only a tiny stringy connection between the lobes, and there's always more than two. Of course, if you counted them and you took somebody with megaloblastic anemia, that number, or that average number, would go up. I think I heard once, actually I counted them once, the average number of lobes per neutrophil is about 3.5. Okay, neutrophils are produced in red marrow. Okay, they sequester in the spleen, and they live in the peripheral blood. There is a hell of a lot more neutrophils in the non-peripheral blood than there is in the peripheral blood. So if you took all the neutrophils that are in the spleen where they sequester, and all of them in the marrow in which they're produced, it's about 50 times as much as what you see in the peripheral blood counts. Their lifespan is only about a couple of days. Now, I know what you're thinking. You're thinking, my God, how could the ratio between neutrophils or granulocytes and red cells be so high in the marrow but so low in the peripheral blood? Remember, it's 1 in 1,000 in the peripheral blood, but it's 3 to 1 in the marrow, and that's because of the lifespan. The red cells live 120 days. The neutrophils live only a couple days. High turnover cells. Generally, the higher the turnover of the cell, the more sensitive it is to not only radiation, but things like neoplasia as well. Here's your neutrophil. Would you like to call it a leukocyte? You can, except a leukocyte is technically any white blood cell. Would you like to call it a poly? I would love to. Would you like to call it a neutrophilic granulocyte, as to differentiate it from another type of granular cell like an eosinophil or a basophil? But generally they're called granulocytes without an adjective. Would you like to call it a polymorph? Would you like to call it a PMN for polymorphonuclear leukocyte? Or would you call it a PML? Probably the best overall term is just a neutrophil. And if you want to prove you're cool, call it a poly. There you go. There's your 3 lobes. There's your little string connecting the 2 of the lobes. And here is your myeloblast, in which there are no granules in the cytoplasm. There's absolutely no cytoplasmic differentiation. You notice there are 3 nucleoli here, however. Usually there's more than 1 nucleolus. Now remember, on the Giemsa stain and on the right stain, the nucleoli look lighter than the rest of the nucleus. On regular H&E tissue stains, the nucleoli are always darker. Okay, here is another cell that has maybe 1 or 2, maybe even more nucleoli, but it's starting to get granules now. This is a promyelocyte. Once the nucleolus goes away and the granules now change from azurophilic to the redder ish granules, orangiophilic, or they might call these primary granules, you might call these secondary granules. You now have a real live myelocyte. And remember, the myelocyte is round, but once it starts to indent, that's called a metamyelocyte. Still having the regular granules, the secondary granules that the mature neutrophils have. Here's a band or a stab, and there's your neutrophil. Just to make sure you're all there, tell me what that little purple thing is there right next to it. Then I'll feel really, really good. I think most of you know that's a platelet. Thank you. I could see got some responses here. So here's your neutrophil maturation. Now, the thing I want to emphasize with you is that you really cannot call a myeloblast a stem cell, but in a way it is, because it basically gives rise to all of the cells in the neutrophilic series, or even more if it's at a higher level. But just remember one thing. I think I'm going to tell it to you about 20 times. A blast is a blast is a blast is a blast is a blast. So if there's no granules in the cytoplasm, you can't call that a myeloblast. Once it goes into promyelocyte, you can. You can't call it an erythroblast. You can't call it a lymphoblast. Just remember, if the only thing you learned how to do in the next 2 days is identify what a blast is, someday you may save somebody's life. There's some blasts now as they look in perhaps a tissue section. I think you could see that there's a nucleolus there, a nucleolus there, a nucleolus there. Do you see how they're a little bit darker? No, I could probably widen this up a bit. Do you see how the nucleolus there and the nucleolus there and the nucleolus there are darker than the actual thing? That's a regular H&E stain. But in the so-called hematologic stains, like the bone marrow stain of Giemsa or the Wright stain on your office peripherals, they're lighter. By the way, what are these three guys here that are hanging around with the red cells? Somebody want to give me a quick answer? These, of course, are the erythrocyte precursors, okay? These are the normoblasts. Some people call them rubroblasts as well. And they generally all stay in the marrow as well. They don't leave the marrow until they lose that nucleus. And the cytoplasm gets smaller. The nucleus gets smaller, the nucleus gets denser, and the cytoplasm goes from blue to gray to sort of a pinkish thing here. And here's a couple of cells as well. You can see they have granules, and you can see they have a nucleolus like there, and you can see you have a nucleolus there. So anybody want to guess as a kind of a quiz question what these cells are? They're big cells like the blast, but they have granules now, and they still have a nucleolus. This is your classical promyelocyte, okay? So if you were to look in a peripheral smear or a bone marrow, and everything you saw was this, the kinds of cells, or the vast majority of them, you'd have a diagnosis of acute promyelocytic leukemia. Okay, we talked about granules, so let's talk about them some more. In the earlier cells, like the promyelocyte, you have what they call the primary granules. They're also called azurophilic because they're bluer than the granules that you see in the mature granulocytes. They're also called non-specific, as opposed to the more mature cells beyond the promyelocyte stage, which have redder granules, so they're called not azurophilic, but they're called now more specific or more secondary. And a lot of them have the same amount of material in them. They're all lysosomes, as you know, so they all have lysozyme, and lysozyme is a primitive sort of substance which is very good against for general bacterial digestion, but it's not specific, so it's part of innate immunity rather than adaptive immunity. And of course, if you want to think of the primary granules of having the acid hydrolases, while the more mature have the alkaline phosphatases, you can. And now you have more specific things like collagenase to start to digest collagen. Lactoferrin, I believe that's only in the secondary ones as well. This is what These cells might look like in a regular H&E over here on the left. You can still see they have granule nucleoli. These could very well be either promyelocytes or something like that. And in all practical purposes, you look at this, you don't know what the hell it is. But let's say that you did an immunostain or a immunochemistry, which is directed against lysozyme or myeloperoxidase stain, which is directed against lysozyme, okay? Or I'm sorry, which is directed against peroxidase. Then it'll look like this. So you know that these cells now are in the myeloid series, and they're very early because they have nucleoli. Sometimes, or originally, the myeloperoxidase or peroxidase stain was used to identify whether blastic-looking cells were of either lymphoid or myeloid origin, because the myeloid cells will have it, but the lymphoid cells don't get granules, if you remember. So we did the chapter on inflammation. We did this. We'll kind of say it again, you know, the functions of the neutrophils. They marginate, okay, they tend to travel towards the periphery of the bolus. They then start to roll upon each other. They can then adhere to each other and to the endothelium. They can then transmigrate or diapedese through the wall. They then have a variety of substances called chemokines, which directs them to the area that they have to work in outside of the blood vessel. They then do their things by recognizing, engulfing, and killing or digesting with their lysosomes, various bacterial or other protein substances. And remember, they're in constant equilibrium with the splenic pool. So you might think of the concept of compartmental analysis, where you have a certain amount of neutrophils in the peripheral blood, but that's in constant equilibrium with the splenic pool, which is much, much, much larger than the peripheral blood pool, as well as the pool in the bone marrow as well. So those are your three pools. And depending on what diseases are present, you'll have shifts in cells from one pool to another. And of course, the neutrophilia that you see with acute infections, those neutrophils are coming from other pools. Most people think they're coming from the bone marrow, but they're really coming from the spleen, okay? But they're really coming from both places. Okay, let's talk about our first classical neutrophil disorder. It's always at the beginning of the discussion in the hematology chapters of pathology books. The Pelger-Hewitt anomaly. It's an autosomal dominant disease. It's not a serious disease. I use the word cute. I don't think any disease is cute, but very often when the hematology texts see Pelger-Hewitt anomaly, they call everybody over and everybody smiles and go, oh, that's really nice. So it's inherited, it's autosomal dominant and follows the classical autosomal dominant features, like a lot of variability, and it doesn't very often appear early in life. Now, what is a Pelger-Hewitt cell? Pelger-Hewitt cell basically looks like a band. It's bilobed. So in somebody with a significant Pelger-Hewitt anomaly, most, if not all, of the cells will look like bands. But that's not really totally true, because do you see that these two lobes are connected by a stringy type tiny thing? And I told you that in a band, the isthmus is about as thick as the lobes. And the isthmus in the Pelger-Hewitt is a little bit smaller, but it still doesn't go beyond the band stage. So if you're looking at a peripheral smear of one of your patients, this is not a rare anomaly. If you're looking at a peripheral smear in your office and they look like normal neutrophils, but everything is bilobed, you know, think of the Pelger-Hewitt anomaly. Now, if it's acquired, they often call that the pseudo Pelger-Hewitt, but it looks the same. Maybe not as many band-looking cells. In the genetic classical autosomal dominant disease, it's called the true Pelger-Hewitt and not pseudo. Okay, the other quick little thing that's often mentioned is the Chediak-Higashi syndrome. This is another less common white cell disorder. It's not autosomal dominant like Pelger-Hewitt. It's autosomal recessive. And it's not acute and incidental. It can be serious, especially in kids. In the Chidiac-Higashi syndrome, you have large purple neutrophilic granules. And not only are they large, but they don't work very well. So there is impaired digestion of the things that these lysosomes are supposed to digest, like bacteria. So kids with this disorder, remember it's autosomal recessive, so it appears early in life and it's full penetrance usually, often have problems with infections. And very often they describe skin pigment disorders and bleeding disorders with it too. It's not quite as benign and acute as the Pelger-Hewitt. Okay. After we cleared away those two things, let's talk about now the concept of neutropenia. Just like we talked about erythropenia, just like we talked about plateletpenia or thrombocytopenia. So whenever you talk about decreases of any type of white cell, whether you could say the word leukopenia, but I prefer the term neutropenia because remember, leuko is any white blood cell, so technically a lymphopenia could be a leukopenia too. Unfortunately, commonly the word leukopenia is used synonymously with neutropenia. In a severe form, you might call it agranulocytosis, or the absence of granulocytes. So why would granulocytes be decreased? Well, the same reasons why red cells or platelets would be decreased, either because of inadequate production or increased destruction. Now, if you remember, we told you that about 6 to 11,000 was the normal value for all white blood cells. If they drop below 1,000, and even if it's significantly below 1,000, that's the danger zone. These are the people that could die from overwhelming, infection or the inability to handle infection properly. And there's a whole long list of things. We're going to go into it. By the way, I put a bunch of drugs here, and this is no joke, or maybe it was a joke, but the list of drugs which can cause neutropenia, leukopenia, is so large. You can see here, this is only the tip of the iceberg, and these are the more common ones. I have about 20 or 30 of them here. It's so large that it's best to think of any drug as causing a potential suppression of white cells. So before your patients go on any long-term drug, you should do a nice CBC with a white cell count. Let's talk about first the concept of inadequate production, just like we did with red cells, with the iron and megaloblastic anemias, or just like we did with the platelets. Now remember, when we talked about aplastic anemias, we said it's usually not just the red cells that are suppressed, it's usually the other cell lines, the platelets and the white cells. So suppression at the stem cell level, the level at which gives rise to those 3 cell lines, would be a very common concept of inadequate production. So a leukopenia of aplastic anemia would also have probably a patient who is anemic and thrombocytopenic as well. We gave you a long list of drugs, and remember, not only can the drug interfere with its proper production, like chemotherapy, obviously. I'm not going to list you the names of the different chemotherapy. All the chemotherapy interferes with white cell production. In fact, the white cell count is the main index for measuring the both efficacy as well as safety, or perhaps overdosing on chemotherapy. So when do they tail off on the chemo? It's when the white cells drop, And if the white cells drop on a patient with chemo, that's the reason. Okay, there's a long list of antibiotics. We mentioned that. Even common things like propylthiouracil, the drug for hyperthyroidism, phenylbutazone. These are all common drugs which are commonly associated with suppressing the production of neutrophils. Okay. Now remember, we also said that with the megaloblastic anemias, there can also, that same DNA suppression can be seen in both the platelet line as well as the neutrophil line. Well, that's another common reason. And look at, we're going to talk a little bit later, maybe tomorrow, about the concept of a myelodysplastic state. Probably the best definition of a myelodysplastic state would be a pre-leukemia. So before your white cells go out of control and pack the marrow and proliferate in your peripheral blood, perhaps 100 times more than they should, they go through a area often of suppression as well. So a pre-leukemia can have decreased white cells due to inadequate production. But the full-blown leukemia is now the opposite, isn't it? There's also a genetic or congenital disease, just to let you know, called Kosman syndrome. It's autosomal recessive, so you know it's full dominant, it's fully penetrant, appears early in life, all that stuff about the AR. And it's also associated with inadequate production of white cells as well. And once again, I'm using the word white cell, you know, but I really mean neutrophils. It's the association between the term white and leuco and the specific neutrophils is so common. It's just used universally by just about everybody. Now, just like we said that in the anemias of impaired or inadequate production, and in the thrombocytopenias of impaired or inadequate production, usually see hypoplasia of those cells. Well, also is true of the granulocytes as well. So if you have a granulocytopenia or a neutropenia, or if you want to say leukopenia, which I don't like, that is due to inadequate production, then they're not being produced enough, so the marrow will be hypoplastic. Now here's the concept. What if you had a granulocytopenia that was due to increased destruction rather than decreased production? Would you expect the opposite? Would you expect granulocytic hyperplasia then? Yeah, that's the whole concept. Okay, so let's talk about the leukopenias of increased destruction. The same concept with red cells and platelets. Most of them are immune mediated. In other words, autoimmune, like in lupus. And if you remember when we had that list of symptoms in lupus, the number one most common symptom in a lupus patient is anemia, because not only are they attacking their own DNA of the liver and the kidney and the blood vessels and the brain and everything else, but also the red cells and the white cells and the platelets as well. Now, you can also have increased destruction by drugs by sensitizing the membrane, the cell membrane of the white cell, and therefore making it more susceptible for early destruction. So that would be an example where a drug does not interfere with its production, but it alters or sensitizes the cell membrane to make it more susceptible to increased destruction. Now, what happened if your spleen was enlarged due to portal hypertension or any reason for causing an enlarged spleen? Well, not only would it be large, but it would be acting large as well. So if somebody that has a large spleen simply due to portal hypertension, let's say, is going to be hypersplenic functionally as well, and therefore they'll be destroying not only their reds, but their whites and their platelets as well. What about if you have overwhelming infections? This is seen especially in the fungal infections, but also, you know, the general stimulus for neutrophil release are bacteria as well. When the infection is overwhelming and you have an increased need, then there are mechanisms, you know, like colony stimulating factor, all the other cytokines, to make those show up as granulocytic hyperplasia in the marrow as well. So the same concept we said with red cells, The same concept we said with platelets applies to neutrophils or white cells in general, is that increased destruction is granulocytic hyperplasia, and inadequate production is usually manifests itself as granulocytic hypoplasia. Okay, what about the opposite now? What about leukocytosis neutrophilia? This is very, very, very clinical. You know that there is a compartmental equilibrium between the marrow and the spleen pool and the peripheral blood. A leukocytosis or neutrophilia is simply an increase in the peripheral blood. So there's a shift from one of these pools into the circulation. And that's usually from the spleen, but also because you often see increased in white cell or granulocyte precursors like bands and even myelocytes. They also come from the marrow as well. So remember, this is a very living sort of homeostasis or equilibrium between these three pools. So when you see the neutrophils are increased in your patient, don't think that they're coming directly from the marrow. They're probably coming from the spleen as well. And the non-vascular pools, this one blew me away. Think about it. If you have 5 to 10,000 WBCs per cubic millimeter, and then you have like about 5 liters of blood on top of it. You could do the math, and you could probably figure out how many neutrophils you have floating around, and realize that neutrophils are about 2/3 of the white cells. But there's 50 times as many in the non-vascular pools. Isn't that something? So the general response is you have your mothers of all cytokines like TNF-alpha, interleukin-1. We've seen this in so many other things. We talked about this in acute inflammation. They are now stimulating T cells to produce CSF, colony stimulating factor, and this is the main substance at various levels, which tells the marrow to produce more WBCs. It's like the EPO equivalent for red blood cells. So if you wanted to think of CSF is to neutrophils as EPO is to erythrocytes, that's a very, very nice logical concept. Okay, so here's your neutrophils, and let's just say they're increased. Well, for most of the reactive, inflammatory, infectious reasons that cause a neutrophilia, you will probably see a little more prominence of the granules as well. So sometimes the granules look a little fine, but they're a little bit coarser whenever there's a neutrophilia due to an infection or tissue necrosis, and those are called toxic granulations, okay? Sometimes that same reason causes you to see another substance. You could see here, maybe we could make this a little bit bigger, I hope. You see that little blue guy over there? That's called a doily body, D-O-H-L-E with an umlaut on top of it. And that's also associated with granulocytosis as well. Let's see if we could find another one. Yeah, there's another one. Not only is that bigger than a toxic granulation, but it's a different substance. The toxic granulations are just bigger lysosomes. The doily bodies are actually fragments of RNA. Okay? Here's another one over here. Look at that. Remember, these are not our rods. Our rods are something that are redder, and you're going to see with leukemias, and not just with neutrophilia. Okay. What about increases in eosinophils now? Well, it's called eosinophilia. And to make a long story short, we could rattle off all of the substances in those cells which make the granules of eosinophils, like eosinophil peroxidase, like eosinophil cationic protein, like eosinophil-derived neurotoxin, like major basic protein. They all have nice acronyms, as you can see here. But to make a long story short, let's be very, very clinical, because in your life, whenever you see a patient with eosinophilia, you're not going to try to recall or memorize these acronyms down here. You're going to say, what's causing it? And it always boils down to two things: allergies and parasites. And of course, if you're seeing patients in hospitals, I think a drug allergy is probably the most common type of not only allergy, but the most common type of reason for eosinophilia. Not just in the peripheral smear, but also in the bone marrow, when you see an increased number of eosinophil precursors as well. Think of a drug allergy, or think of a parasite, okay? Now, is there such a thing as a specific eosinopenia? I can't think of any, so my answer is no. Now, if you want to Google something, maybe you could find something, but whenever you see an eosinopenia, just like whenever you see a basopenia, for example, it'll never be specific. It'll always be associated with suppression of other cells as well, like an aplastic anemia or a leukopenia in general. So let's move on to the basophils. Basophilia, we talked about basophilia regarding staining properties of cells, using hematoxylin and eosin. But basophilia as a concept of a specific increase in basophils, it's very, very, very rare. They say that in some of the myeloproliferative diseases, you'll see an increase of basophils, but they're usually not just basophils. There are also increases of other white cells as well. So just remember, the basophils should never be over 1%, and if they are, they're probably also increases of other white cells as well. So same question, same answer for eosinophil applies to basophil. Is there such a thing as a specific basopenia? The answer is no. Now, I guess if you were to look at the differentiation of all cells, from the myeloid series, and there was a specific genetic defect involving the maturation of a basophil somewhere, you might see it. I just have never heard of the disease, but there might be one. If there is, I'm just not smart enough to know it. Here's the other big cell now called a monocyte, and we've been talking about macrophages forever during this course. But before the macrophage goes into tissues and is still floating around in the blood, it's called a monocyte. Okay, so what would be a reason for a monocyte increase? Well, I'll give you a little rule of thumb. If you remember, when we talked about granulomatous diseases, we said that the chief cell of granulomatous inflammation is a macrophage. So the diseases very often, which are granulomatous, like TB is the big one at the top of the list. Even though I got 5 other things there, TB is most of them. The granulomatous diseases, ulcerative colitis and Crohn's disease is sometimes a granulomatous disease. In fact, Crohn's disease is called granulomatous colitis. Another thing you should remember is that autoimmune diseases, malaria, rickettsia, SBE, subacute bacterial endocarditis, you can see a lot of monocytes coming out there as well. Whenever you see a lot of monocytes increasing in the vascular pool, you could bet that a lot of those guys are going to be going out of the vascular pool and diapedicing into the tissues as well. In this case, tuberculosis, but all these other diseases as well. Okay, we've neglected the second most common cell. It also might be one of the most important cells, and those are lymphocytosis. Okay? Here's a good general rule. We said that the main cause of a significant monocytosis was TB, but also at the top of the list for lymphocyte increases is TB as well. Now, I don't know if you've noticed a pattern here, but there are a good number of viral diseases which cause a fairly specific lymphocytosis, like hepatitis, especially hepatitis A, CMV, which is in the herpes family, EBV, Epstein-Barr virus. I believe that's also in the herpes family. You could check it if you want. Now, in kids, the most significant reason for a significant lymphocytosis is whooping cough, pertussis. That's a bacteria. So let's keep that in mind. But if you take kids out of the picture, you might think that a general rule of thumb, a very loose rule of thumb, because there's a lot of exceptions to it, is that viral infections are generally more likely to cause more of an increase in the lymphocytes, whereas the common bacterial infections would perhaps have more of a predilection to cause increase in granulocytes. I don't know if that's a good rule. I don't know if I should preach it as Bible, but in pathology you see it time and time and time again. So I'm not going to make you stand up and raise your hand and say bacteria, granulocytes, viruses, lymphocytes, but it's a principle you might want to keep in the back of your mind. Okay, let's look at the time. We probably got a few minutes to at least talk or get introduced to the concept of myeloproliferative diseases, and they are no stranger to you because we talked about the concept. We talked about red cell disorders. We talked about P or polycythemia vera as being one of the myeloproliferative disorders, which is a general proliferation of the marrow. But in P vera, the primary peripheral expression was red cells. So these are patients with elevated hemoglobins, elevated hematocrits. Let's say in a proliferation of the marrow in general, you had the primary expression was leukocytes. Then that might be called CML. Now, even though the L in CML stands for leukemia, and CML is chronic myelogenous leukemia. Sometimes it's called CGL for chronic granulocytic leukemia. They are considered more of a generally sort of a benign proliferation of the marrow, even though maybe 10 or 20% of the CMLs can go into acute leukemia. Most of them do not. Or let's say that your marrow proliferated generally, like all of these do, but the primary peripheral expression now was platelets. Then that myeloproliferative disorder would be called essential thrombocythemia. My dad had it, by the way. It's also called essential thrombocytosis. They're the same terms. The word essential means myeloproliferative. Finally, there's a fourth one called myelofibrosis, and this is significantly more dangerous, worse prognosis than the others. So whereas the CMLs can go into leukemia, acute leukemia, the P veras normally don't go into leukemia. The essential thrombocythemias, which are rare, normally do not go into acute leukemia. Myelofibrosis can go into acute leukemia quite often, okay? And not only does it go into acute leukemias quite often, but very often it's the result as a long-term presence of the previous three. So when they talk about primary myelofibrosis, they're talking about something that has occurred spontaneously. When they talk about secondary myelofibrosis, they're talking about something that may have arisen after many years of a long-standing myeloproliferative disorder of the other three. And finally, I think I know how you would also visualize myelofibrosis. Whereas these three myeloproliferative disorders are absolutely loaded and packed with hematopoietic cells of all types, this is also a hypercellular marrow, but the primary cell is a fibroblast, so it's a true myelofibrosis. We'll get into more detail, So, what are the general features now of myeloproliferative disorders? Well, first of all, it's a general trilinear proliferation of marrow cells. And remember, it's not the same as a myelodysplastic. Whereas some of the myeloproliferative disorders may go into acute leukemias, they're all extremely hyperplastic, hypercellular. The myelodysplastic disorders frequently go into acute leukemias, but they are not generally hyperplastic or hypercellular. In the myeloproliferative disorder, all three marrow cell lines are affected, and I'm going to put the word 3 in there because often the word trilinear is used, meaning reds, whites, and platelets. They also produce a very significant splenomegaly, and sometimes part of the reason for that splenomegaly is not only is the marrow increased in cellularity, but it may also expand into the yellow marrow. So in an adult, you may have red marrow, which is normally in the axial skeleton, expanding into the appendicular skeleton, and even expanding into the things like spleen and lymph nodes. So if you want to think as proliferation of the marrow as a three-dimensional process, you can, because the first dimension is just rather than have a normal 50% cellularity in the marrow, it may be 80, 90, 100. The second dimension is expanding beyond the area where the hematopoietic marrow should be, and that's strictly in the axial skeleton. It may expand in another dimension into the appendicular skeleton, into the femurs, into the humerus, shafts, not just stopping at the femoral heads and humeral heads. And thirdly, it may expand into other organs as well. So when a myeloproliferative disorder expands into an organ where marrow is usually not produced, and the spleen is the most likely, but also in the bone marrow, that's called extramedullary hematopoiesis. It's also called myeloid metaplasia because it's production of myeloid cells in an area where normally they're not produced, like the spleen or lymph nodes. Okay, that's a general concept of myeloproliferative disorders. What we'll do is we'll take our 10-minute break, and then we'll go into the four common ones and look at some of the specific features of each one. But I tried to put all of them together in one picture here, and I'm very proud of how you can just look at them all as being in the same general category disease as marrow expansion. Okay, we'll drop this down. We'll go back to the iguanas over here. You know, this picture has been on here before, but I put it on again simply because I love it so much. To me, this was the high point of my entire year, because not only did we do something historic and teach a medical school class from the jungle, but I also met, coincidentally that day, the most famous person in Puerto Rico. And he's a rap singer by the name of Daddy Yankee. And the two things occurred on the same day. And it was, when I went home that day, I was so elated. I didn't even know if my body was touching the bed when I went to sleep. So we're only going to have one song now for the break, but it's going to be a 10-minute song. And it's going to be the same group that started you out. It's going to be the Doors. So everything that we play today is going to be from my favorite rock group of those very troubled times called the 60s, the protest. Of course, nowadays, they seem like they're happy times with all the crap that's going on now. So let's start you out with my favorite Doors song and show you on the slideshow something that we called psychedelic.
When the music's over, when the music's over, yeah. When the music's over, turn up the lights, turn up the lights, turn up the lights. When the music's over, when the music's over, when the music's over, turn up the lights, turn up the lights, turn up the lights. Well, the music is your special friend, playing some fires in the engines. Music is your only friend. Until the end, until the end, until the end. Cancel my subscription to the resurrection. Send my credentials to the house of detention. I got some friends inside. A face in the mirror won't stop. The girl in the window won't drop. A beast of friends, alive she cried, waiting for me outside. Before I sing, a big sleep. I want you here. I want you here. The scream of the butterfly. Come back, baby, back into my arms. We're getting tired of hanging around. Waiting around with our heads to the ground. I hear a very gentle sound. Very near you, very far, very soft yet very clear. Come today, come today. What have they done to the earth? What have they done to our fair sister? Ravaged and plundered and ripped her and bit her. Stuck her with knives in the side of the dawn and tied her with fences and dragged her down. I hear a very gentle sound. With your ear down to the ground. We want the world and we want it. We want the world and we want it.
Now.
Yeah.
Now.
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 So when the music's over, when the music's over, yeah. When the music's over, turn out the lights, turn out the lights, turn out the lights. What the music is your special friend. Dying sound fires, Indian turns.
I assume you're still here, and I think our RAM froze up a little bit, so I'm trying to get rid of the screen here. Here we go. Maybe we can close it down now. I'm assuming you're all still there. Give me a second. Yeah, I have to get rid of this computer sometimes. I just think we got to do something about this here. I don't want to have to start the webinar again, and we just had a freeze up of our RAM, which is why we had some sound lapses. Okay, here we go. I think we can get rid of this thing now. Oh, wow. Sorry, folks. This is just a little glitch, and I think I could fix it in a couple of seconds here. We really tied up our RAM here. Okay. Can you hear me, by the way? You may be able to hear me, but I don't know if I could get your responses. Okay, we're going to close this down and free up. Okay, you can hear me. That's good. We're closing down the show. Give me a second. Oh, we got a little bit of a RAM freeze up here. Oh, I think it'll probably decide to quit puking in a few seconds. So let's close the damn thing up. It won't let me put my pointer to close the window, though. Oh, maybe now we can do it. There we go. I think we got it now. Oh, sorry for the delay, folks, but I hate this. By the next time we do a show, I'm going to have a new computer up here. This one just does not have enough RAM. And it also won't let me close down the damn window. Okay, so we've already done what we wanted to do, so I'm happy about that. We're back. That was Jim Morrison in the Doors doing his longest song ever, When the Music's Over. It's one of my favorite songs. You might have noticed that the picture or the slideshow today happened to match with the theme, and that is the troubled 60s, the Doors, the psychedelic era, the era of pot and acid. Probably the thing I was the most proud of in college is that I never smoked pot or took drugs. Almost everybody else around me did. But I felt that if I had experimented with that, my chances of getting into medical school would be pretty much shot. So I'm very proud to say I never took drugs. And when I got into medical school, the proudest thing I could say is that I didn't have the highest grade in the class, but I certainly never had to ask my parents for money because I was able to work my way through. So those are my two areas of joy that I'm bragging about now. We're going to continue. And I wanted to ask you the question first is, did you hear me well during the first half without any interruptions? Okay, good. And were you able to hear the music and the slideshow pretty well during the break, except for maybe the last minute or so? Okay, good, good, good. So let's go back up to chapter 14 here, WBC. And I'll feel very confident that nothing serious got screwed up. We talked about the concept of myeloproliferative diseases. Now let's talk about the four common ones, or maybe I should say the main ones. And the first one, the mother of all myeloproliferative diseases, is called CML, chronic myelogenous leukemia. You can't think of it as an acute leukemia, even though it could sometimes, and maybe about 10 or 20% of the time, progress into a condition called a blast crisis, in which you have an increased number of blasts in your bone marrow and your peripheral smear, and then it is regarded of having gone into acute leukemia. It's a disease of elderly, or we'll say adult people, usually over 60, And the hallmark feature, which we've known about for many generations, is a so-called Philadelphia chromosome. Most of the CML patients have the Philadelphia chromosome, and that's why they have the disease. The chromosome is actually a fusion between chromosome number 9 and number 22. You might call it a translocation as well, because it's partly translocated or fused. And actually, research in this fusion has actually led somebody to not only a Nobel Prize, but to a very, very, very significant breakthrough in the control and treatment. And so I would even like to use the cure word sometimes in this disease. So chronic myelogenous leukemia is a myeloproliferative disease, just like P. vera is a myeloproliferative disease involving all cell lines, just like P. vera is also all cell lines. But the primary peripheral expression is granulocytes. So when you look at the bone marrow of a CML, it's not 50% cellular, which is normal, but it's usually 100% cellular. I had a very good hematology friend, and I told him once that CML is like 90% cellular, and he corrected me. He said, "Oh no, take a good look. They're all 100% cellular." Now, because they are, you would imagine that the normal M to E ratio, which is about 3 to 1, is probably 8, 9, 10, maybe 20 to 1. And whereas the normal neutrophil count is 5 to 10,000, it's not unusual for it to be 10 times as much, okay, 50 to 100,000 even. But there is not a significant amount of blasts in the peripheral smear. Usually it's less than 10% blasts. Once it gets over 10% of those cells actually being blast cells, then you start thinking maybe this is going into a blast crisis. Also, in your lifetime, the most significantly enlarged spleens that you will ever see, in the United States at least, I shouldn't have said your lifetime, but is they usually have massively increased splenomegaly. It's not unusual for a spleen to weigh as much as the liver, or 10 times as much in a chronic myelogenous leukemia. And of course, research into that fusion between chromosomes 9 and 22, in other words, drugs that are called kinase inhibitor of the BCR-ABL fusion, has resulted in a 90% remission rate in this disease. Here's your bone marrow. And like I said, it's not just granulocyte precursors. It's also, you can see gazillions of megakaryocytes there as well, which are the big cells. And if you were to look at it in a better stain, like a Giemsa stain or higher power, usually a lot of those are red cells as well. But the primary peripheral expression is granulocytes. Now, I know what you're thinking. You're thinking, well, Dr. Minarcik said that the marrow is 100% cellular or 0% fat. But I can see big wide spaces here, and here, and here, and here, and here. Well, that's not fat. Those could be blood vessels. I think they could possibly be. But I think it's a fair statement to say this is a 100% cellular marrow, and it is not a uniform sheet of the same type of cell like metastatic cancer or blast. This is still trilinear, heterogeneous maturation. Okay, here's a closer up pic, and you can see there's a very abundant amount of megakaryocytes here as well. This patient probably not only had granulocytes massively increased, but probably platelets as well, but the primary peripheral expression was granulocytes. If the same marrow, the primary peripheral expression was thrombocytes or platelets, you might call this an essential thrombocytosis or an extensional thrombasthenia. Now, this is the second disease, which we've already discussed. We'll briefly mention it again. P. vera, like CML, is a trilinear overproduction of all 3 cell lines. The primary peripheral expression is red cells, increased hematocrits and hemoglobin and red cells, but it's also very often a lot of platelets too. And because of that, you can have thrombosis because there's a lot of platelets. But the platelets are frequently abnormal, so they don't work very well. So you can also have bleeding as well as thrombosis. People with P. vera are very, very high risk for thrombosis. They're also at high risk for gout as well as the other myeloproliferative diseases, simply because with the high turnover of nucleated cells, you have a high turnover of purines, which is in nuclei, remember, DNA, so they very often get gout as well. Now, they don't generally go into the blast crisis like the CML, but any of the myeloproliferative diseases with enough time can progress into this myelofibrosis, characterized by a fibrotic marrow, which has a pretty high association with acute leukemias. Here's a P. vera patient. You can see it's not 100% cellular. There's about fat, but it's only about 20%. You can see there's also increased in megakaryocytes. There's one there. There's 5 or 6 there. And this is a typical picture for P. vera. Now, in all honesty, if I was to show you P. vera, essential thrombocythemia, a CML, just the marrow itself, you might have a hard time differentiating the disease. But remember, it's the primary peripheral expression that determines the disease name. Plus, you know, CML and P. vera are 2 different diseases. CML, you know, the problem is the so-called Philadelphia chromosome. And you know that in P. vera, the problem is that you have an extremely sensitive, high sensitivity to EPO, okay? But they're both hyperplastic, hypercellular marrows. P. vera is usually not 100%, but it's pretty high there. So here, I'll ask you the question. Give me your opinion. What percentage of this field here is cells versus fat? I got a number in my mind, and I want to see if you agree. I'm seeing a 90, I'm seeing 80, I'm seeing 85. Yeah, you're about right. You know, I guess the definition of whether you're right or not is if you agree with me. How do you like that? The third myeloproliferative disease, primarily the peripheral expression is platelets. Marrow might look like the other 2. The general rule is if your platelets are over 1 million, it's probably due to a myeloproliferative disorder, and maybe a specific myeloproliferative disorder involving platelets, which is called essential thrombocytosis or essential thrombocythemia. It's very rare in general. I think I've only seen like 2-3 cases in my life. The interesting thing is my dad had it. Often because the platelets are increased and being released earlier, they're being released generally a little bit bigger than normal. So do you remember we have this concept of a MCV, or a mean red cell corpuscular volume? Well, you can do the same thing for platelets as well. You can actually measure the average diameter of the platelet. So very often in essential thrombocytosis, the MPV, or the mean platelet volume, because they're bigger than normal, is increased as well. And you also remember that the RDW was a measure of the variability in size of the red cells. Well, you can probably theorize an RPW, which is a measure of the variability in size of platelets as well. But any condition which causes early release of younger, bigger platelets would probably cause an increase in RPW. And of course, if I told you that in the average bone marrow on a high power field, you might see 0, 1, or none, or maybe 2 megakaryocytes. In these, it's a lot more. Okay, so we saw this one field here in which it looks like there were 6 or 7, and this is a very high power field. And this is classically what the megakaryocytes might look like if you smeared the marrow. And you could see not only are they massively increased, but they're not quite fully lobulated, developed. You can see that they're megakaryocytes because they're 10 times bigger than all the other cells. But you notice the lack of lobulation of the nucleus. They're generally smaller megakaryocytes than normal, and they're not quite as lobulated and mature. Okay, I think we're done, except for the last myeloproliferative disorder called primary myelofibrosis. And it's the most serious of all. It's generally in an older age group and often follows after many years of the other myeloproliferative diseases. And the two things you should remember about this, you already know that there's fibrosis because of the name, but the other thing you should remember is that the marrow is expanded, but because there's so much fibrosis in the bone marrow, the cells want to be made somewhere else, like the spleen, like the lymph nodes. So primary myelofibrosis, or any myelofibrosis, is always associated with red cells, white cells, and platelets being made in other places besides the bone marrow, like the spleen or the lymph nodes. This is also called myeloid metaplasia or extramedullary hematopoiesis. So very often when you hear the word myelofibrosis, they'll say myelofibrosis with myeloid metaplasia. And there are ways you could tell if, for example, iron is being taken up and utilized by the spleen. There are ways you could tell. You can also look at it microscopically as well. Disease also has a leukoerythroblastosis, or of an increased number of both erythroblasts and leucoblasts in the peripheral blood. And that's a very ominous sign because, like CML, a good number, I used the range 10 or 20% can actually progress to acute myeloid leukemia. And it's probably not surprising that when you look at this bone marrow here, you can see this is a nice spicule of bone. I think you can see maybe this is a remnant of a fat cell. I think you could see generally it's hypercellular, hyperplastic, but they don't really look like those loose hematopoietic cells. So when you look at a marrow like this, the first thing your mind says is, this is screaming for a trichrome stain, because you know that most of these connective tissue like spindly cells are fibroblasts, and probably collagen is one of the main components in what you're seeing here. That's why they call it myelofibrosis. Okay, let's talk about leukemia. Okay, you know we're going to get around to it. You know that there's leukemias of the myeloid series. You know there's leukemias of the lymphoid series. You know there's acute leukemias. And you also know there's at least one chronic leukemia that we've already discussed as a myeloproliferative disorder. But what can we say about the leukemias in general? Well, in general, leukemia is defined as a malignant proliferation of a white blood cell. Okay? So the general picture of a leukemia is a marrow that is loaded with blastic or almost blastic or primitive type cells. It's perhaps very hypercellular, hyperplastic. Most of the cells are blasts. Many of those blasts get out into the peripheral smear. And because it is packing the marrow is generally now deficient in red cells and in platelets. So most clinical presentations of acute leukemias are anemias and thrombocytopenias. And then you look at their blood on the smear, and there's loaded with blast cells in the peripheral smear. And then you look at their marrow, and very often the chief, if not almost entirely predominant cell of the marrow, is a blast cell. Now, it's very easy to classify the leukemias of the non-lymphoid white cells. But the thing you have to remember is that in all the modern classifications, when you have a malignant proliferation of a lymphocyte or a lymphocyte precursor, these cannot be classified independently of the malignant lymphomas. So the lymphomas release malignant lymphocytes, the leukemias release malignant lymphocytes, and you can't classify them independently. So let's talk about the differences in general of the leukemias and the lymphomas. Well, all leukemias of lymphocytes have lymphoma counterparts. And all lymphomas can send cells into the peripheral blood as well, which is a leukemic phase. And that includes the multiple myelomas as well. Any myeloid leukemia can infiltrate a lymph node, just like it could infiltrate anything. But if or when it does, it is not called a lymphoma. It's simply called a myeloid or a leukemic, non-lymphoid leukemic infiltrate into a lymph node. Now, all lymphomas are malignant proliferations of lymphocytes. Let's get something very clear. The word lymphoma does not have to be preceded by the word malignant. All lymphomas are malignant. Very often, you'll hear the word malignant lymphoma, but it's a redundancy. There is no such thing as a benign lymphoma. Now, all leukemias, whether they're lymphoid or non-lymphoid, they involve bone marrow changes as well. Okay? So, let's talk a few words about the lymphomas in general, then we'll go into them in more details later on. But the malignant lymphomas or lymphomas, they generally occur in lymph nodes, but they can occur in extra lymph node lymphoid tissue like MALT or mucosal associated lymphoid tissue or the spleen or technically even the thymus. But anywhere where lymph nodes, lymphocytes comprise an integral population of the tissue structure is where lymphomas can occur. Most of the time, 90% of the time, more than 90% lymph nodes. The lymphocytes can be either T cells or B cells. Okay? Most of the malignant lymphomas are B cells, maybe 80%, but a good number are T cells. The lymphocytes can look small. You know, we talked about the small 10-micron lymphocyte, or they could be larger. In general, if they're larger, they may be more blastic or more primitive as well. The lymphocytes can occur or be seen as diffuse sheets of cells inside of a lymph node, or they can look like little follicles with little germinal centers, okay? The main differentiation of malignant lymphomas is Hodgkin's or non-Hodgkin's. And even though Hodgkin's is the main word here, it's not the majority of the lymphomas. The majority of the lymphomas are non-Hodgkin's. We'll say maybe 70, 80%, but definitely more than half. The main thing that differentiates a Hodgkin's lymphoma from a non-Hodgkin's lymphoma is the presence of a Reed-Sternberg cells. Let's make a general rule, which I'm sure a lot of the hematologists would jump on me about, but the general rule is if a malignant lymphoma has a Reed-Sternberg cell, it's called Hodgkin's lymphoma. If it doesn't have a Reed-Sternberg cell, it's called non-Hodgkin's. There are some rare exceptions to the rule, but that's the general principle most pathologists use. During my lifetime, there have been, at least a dozen, and I mean 12, at least a dozen classifications of malignant lymphomas. Sometimes they're named after guys like Rappaport or Lukes. Sometimes they're named after countries like France, America, and Britain. Sometimes they're named after T's or B cells. Sometimes they're called international. But one of the main frustrations that pathologists have is every time they think they learn the most currently popular classification, it's taken them 3 years to learn it. They then go to a conference and there's a new one. And we don't know when this insanity is going to stop. Now, the leukemias, however, can be acute or chronic. The difference between a chronic or acute leukemia of any type is that a acute leukemia has a preponderance of blasts in the bone marrow and peripheral smear. The chronic leukemias has more of a preponderance of more mature cells, like mature-looking lymphocytes or more mature-looking granulocytes. The leukemias can be either myeloid or lymphocytic. And myeloid of course, includes everything except lymphocytes. So in erythroleukemia, megakaryocytic leukemia, these are all considered to be myeloid origin, because if you remember in the development of the white cells, there's a common stem cell that gives rise to all the myeloids, and that's different from the common stem cells that give rise to the lymphocytes, whether they're T cells, B cells, or natural killer cells. Leukemias can occur in childhood, often, or they can occur in adults. Now, for example, the lymphocytic leukemias, acute leukemias, more likely at childhood. The chronic lymphocytic leukemias, almost all adults. All leukemias involve the marrow. All leukemias, acute leukemias, suppress the other two cell lines. So if you have a leukemia of white cells, which of course they all are, you're probably going to be suppressing the red cell production and the platelet production. That's why clinically acute leukemias, whether they're lymphoid or myeloid, they usually present as anemia. The patients are very pale, and maybe they have bleeding because of the platelets not being produced because all of the white cells are squeezing them out of the marrow. Many of the leukemias, if not most, have a fairly predictable chromosomal aberration. Every different one is associated with a generally predictable chromosome aberration, which is not present 100% of the time, but there's a long list of them. Now, what does all this mean? Is that some of the leukemias, we've already talked about the chronic myelogenous leukemias having a 90% remission rate with the kinases which would prevent the fusion of those two chromosomes. Now, in the acute lymphocytic leukemias, which is mostly in children, there has also been amazing progress over the last couple of generations as well. Now, see this yellow slide here? This is the single most important slide of this entire, 105 presentation. I'm going to teach you how to identify a blast. This is a blast cell here. It's next to a red cell, a couple of red cells, a bigger red cell, a smaller red cell. It's also next to a nucleated red cell as well. What is the first most obvious thing you notice about the blast? Is that it's bigger. The nucleus, the whole cell, 2, 3, 5 times bigger than all the other nucleated or non-nucleated cells. Big. Number 2, it's the only cell besides a promyelocyte which has at least one and usually more than one nucleolus. Now the nucleolus looks light because this is a right stain. If it was an H&E stain, it would look darker than the nucleus. That's number 2. And what's number 3? Is that because it is a blast cell, by definition, it has no cytoplasmic maturation. There's no granules, there's no nothing. So those are the 3 features of a blast cell. The reason why I make this so important is that many people look at their patients' CBCs in their office, and if you know how to recognize a blast cell, even if there is only 1 or 2% blast cells in your patient's peripheral blood, they probably have leukemia, okay? So your recognition of it can save your patient's life. Okay, somebody said this cell has 3 nucleoli. Yes, it does. It could have 4. It could have 5. It could have 1, but it is a clear-cut nucleus. So I want everybody to raise their right hand and say 3 things. Number 1, blasts are so much bigger than all the other cells. Say it. Number 2, blasts have nucleoli. Number 3, blasts have no cytoplasmic differentiation. Okay, good. You said it. You can sit down now. I hope someday that this one little lecture will enable you to save your patient. Some of the hematologic malignancies The leukemias, the lymphomas, we've already said that they often have very predictable chromosomal translocations. Now, for example, with the Philadelphia chromosome, that was the pattern or the mother of all things, but since then there have been dozens of other predictable chromosomal translocations. You may be asked on the board questions about other ones, but I'm not going to give you the long list of dozens or maybe hundreds. We mentioned in our genetics chapter that the trisomy patients, Down syndrome, trisomy 21, are associated with acute leukemias. We've mentioned that Fanconi's anemia, which is the only type of hereditary aplastic anemia, is often associated with leukemias. Another immune disease, very funny disease, usually have grand rounds on it whenever a patient comes in, called ataxia telangiectasia. So they have cerebellar type problems as well as blood vessels which are dilated. I put a little blurb on it down at the bottom. It's ataxia, it's telangiectasias, especially of the eyes and skin. It's also immune deficiency with low immunoglobulins. They also have chromosomal instability. Their cells are also highly sensitive to ionizing radiation. They have high alpha-fetoprotein, but they also have a high relationship to acute hematologic malignancies as well. Now, in the viral area, that before HIV became HIV, it was called HTLV3. Well, if there was HTLV3, that another retrovirus, in fact, the first retrovirus known to cause tumors in humans, was HTLV1. This is not AIDS. AIDS was HTLV3. So HTLV1 virus, the retrovirus, causes lymphoid tumors. We've said that EBV, the same virus that causes mono, the same can cause a certain type of malignant lymphoma called Burkitt's lymphoma. And you all know the AIDS virus itself, or formerly HTLV3, is associated with a wide variety of lymphomas, especially the B-cell lymphomas. Probably almost all patients with primary CNS lymphomas are also HIV patients. And it also enables one of the herpes viruses, which is not a retrovirus, HH8, to cause another malignancy of blood vessels called Kaposi sarcoma. So these are the relationships of hematologic malignancies with other diseases. I'm going to give you one more slide, I believe, about this. We also know that H. pylori, this is another Nobel Prize guy. I just saw his picture the other day. We all know that H. pylori causes maltomas or B-cell lymphomas of non-nodal tissue. We know that patients with celiac disease, one of the primary malabsorption diseases that we talked about, it's also called gluten-sensitive enteropathy. We know that it's associated with now T-cell lymphomas. And we also know that in HIV, you have a high association of the B-cell lymphomas. Now, isn't that interesting? Even though HIV is more classically a disease of T lymphocytes being suppressed, the B lymphocytes frequently proliferate as lymphomas. Much, much more common to have a B-cell lymphoma with AIDS rather than T. And of course, a CNS lymphoma is regarded as being found in an AIDS patient until proven otherwise. Now let's talk about the acute lymphocytic lymphomas. We talked about the chronic ones, but the acute lymphocytic leukemias, which once again is classified concurrently with the lymphoma classification. I'm not going to show you the long list of each one, but now you have a malignant proliferation in the marrow and the peripheral smear of lymphoblasts. Well, generally, they're in kids, but they can be in adults. Most of them are in kids. It's usually sudden onset. And like any other acute leukemia, they present with anemia, they present with bleeding, they present with fever, they present with bone pain, their lymph nodes may be enlarged, either due to the fact that the leukemia has infiltrated the lymph node, or there's a lymphoma present as well, and they have large spleens. Now, you know what? If I took the L out of here and I put an M in there, this PowerPoint would also be correct, because these are the clinical presentations of the acute myelogenous leukemias as well. So remember, any leukemia, which is acute leukemia, which is the result of increased blasts in the Morel peripheral cell, will suppress the production of the other two cell lines, namely the red cells and the platelets. That's the clinical thing. And specifically with the acute lymphocytic lymphomas, the actual malignant blast, lymphoblasts, by the way, do you think if I showed you 10 lymphoblasts and then I showed you 10 myeloblasts, do you think you'd be able to tell which was which? Yes or no? The no is absolutely the correct answer. The reason is a blast is a blast is a blast is a blast is a blast. It's much more important for you to recognize a blast than try to waste your time figuring out whether it's a myeloblast or lymphoblast. It's like looking at a lymphocyte on a regular smear and saying, is this a T cell or a B cell? You know, you can't do it. You need a special stain. ALL is mostly in kids. At least 2/3 or 80% of them are. Most of them have fairly predictable chromosomal changes. Some of them have the Philadelphia chromosome. Some of them are hyperploid. Some of them have fairly predictable translocations. But look at the big thing at the bottom. In the last couple generations, when I was your age, the response to chemo or the cure rate was practically, it was very dismal. Look at that. We have a 90% remission rates now with chemo. And guess what? 75% of them are permanent remissions. So what do you call a permanent remission? I don't know about you, but I'm not afraid to use the C word. I call a permanent remission a cure. This is a boring slide. It shows that we have a marrow here that's packed with all of the same type of cell. You don't know what it is, but you look at it, and I think you could see that probably, like here's a nucleolus, there's a nucleolus. The nucleoli here are not as nice. Here's a nucleolus as we saw in the other one. And I think you will say, well, doesn't this little blue lip of cytoplasm make you think that maybe it's lymphoid? Remember, a blast is a blast is a blast. Now, if you want to look at these and call them lymphoblasts because they look a little bit more like lymphocytes, you can. But guess what? Somebody's life is at stake, so you better make damn sure they're lymphoblasts rather than myeloblasts. Because if you give them the curative drug for acute lymphocytic lymphoma, leukemia, the kid, and these wind up being myeloblasts, guess what? You just killed that baby. And I don't think you want to live with that, okay? Now, let's look at the chronic lymphocytic leukemias now. And whereas the acute lymphocytic leukemias are mostly in kids, the chronic lymphocytic leukemias are mostly in adults. In fact, I'll go so far as to say even old adults, like me. Most of them are over 60. Now, you want to know the interesting thing? Because the cells of chronic leukemia are not blastic, but they look like normal, mature lymphocytes, you could probably make the diagnosis of chronic lymphocytic leukemia by simply looking at the computerized printout. Because the general rule is if you have somebody over age 60 and they have more than 4,000 lymphocytes per cubic millimeter. Now, we said that 5 to 10 was normal for the total, but only about 20% of those are lymphs. Well, look, in this case, at least half of them are, okay? It can be picked up very easily, identified on a CBC printout. You don't need a pathologist. You don't need a bone marrow. The rule is a sustained adult, older adult lymphocyte count of more than 4,000 per cubic millimeter is CLL until proven otherwise. The text always brought us in the slides anyway, just to make sure that it wasn't something else, but it was a slam dunk, easy diagnosis. You didn't even need a bone marrow exam to prove it. But of course, you will do it anyway, because if you're going to be treating that person, you better know you're looking at the cells, and bone marrow is so easy to do. They are not blast cells. They look like normal lymphocytes. And they can invade lymph nodes. They can invade liver. They can invade anything. And remember, the CLL, even though we're calling the L as leukemia, remember, you can't separate this from a well-differentiated lymphocytic lymphoma. The classification is the same. Now, in CLL, you don't normally get translocations, but sometimes you see trisomies and deletions in the chromosome. So it's a predictable chromosome abnormality as well. And you could do these studies to prove it. But once again, the diagnosis, in all honesty, can be made simply by looking at that little spit out on a piece of paper when your patient comes into the hospital. Not only do these look like totally normal lymphocytes, they're not blasts, they don't have leukeoli, they're totally normal looking lymphocytes, but they're more than 4,000 per cubic millimeter. The thing I'll say about them is that although they look normal, they generally are a little bit more fragile than your average lymphocytes, so it's not unusual to see that a lot of these look like they're smudged, or what they call basket cells. So when you see a lot of the lymphocytes, or actually you can't even tell this is a lymphocyte because there's no cytoplasm. It looks like a nucleus that's been, exploded. When you see basket cells, a lot of them on the smear, and then you look to see, well, the lymphocytes are increased too. That's CLL. Patients with CLL also have hypogammaglobulinemia. That's kind of ironic because, the lymphoid precursors give rise to the plasma cells, which make the antibodies. So a benign proliferation, you might think, might be hypergammaglobulinemia. Whereas plasma cell proliferations result routinely in monoclonal hypergammaglobulinemia. The chronic lymphocytic leukemias are usually low in general immunoglobulins. A lot of them have antibodies against the platelets and RBCs as well, so you can call that autoimmune, can't you? So these patients will be anemic and thrombocytopenic as well. Plus, as a disease progresses and more of the marrow is involved, you may have underproduction of red cells and platelets as well, simply because your marrow is being packed with the lymphocytes. And once again, this is about the 5th time I'm saying it, it cannot be classified separately from malignant lymphomas as well. You know what? We have time to talk about the last kind of leukemia, which is also a malignant proliferation of B cell products, and that's multiple myeloma. And the definition of multiple myeloma is a malignant proliferation of plasma cells. Now, plasma cells are former B lymphocytes. So, but you don't think of it as a lymphoma. You don't talk about it as a B cell, a lymphocytic leukemia. But in the big classification of hematologic malignancies, the multiple myelomas are regarded in the realm of lymphocytes. Multiple myelomas generally are proliferation of lymphocytes within the bone marrow. Sometimes they break out and you can see plasma cells in the peripheral smear as well, but they usually don't. But if you see even 1 or 2 plasma cells, and they are absolutely unquestionable plasma cells, in your patient's peripheral smear, he probably has a multiple myeloma. And because they are proliferating with uncontrolled, they are also proliferating with their products as well, and that's gamma globulins. And they are either whole gamma G antibodies as well as parts like heavy chains, light chains, and specifically the light chains of monoclonal protein can also be shed into the urine, and when they are, that's known as Bence-Jones protein. And yes, interleukin-6, if they have elevated interleukin-6, for some reason, I don't know the reason, it's one of the markers they use as a bad prognosis. Now, let me ask you a question. If the diagnosis of multiple myeloma depends on identifying the cells as plasma cells, do you think that a multiple myeloma that has classical-looking plasma cells would express more gamma globulin than a multiple myeloma where the cells don't look like plasma cells too much? That's the question. Of course, everybody knows the answer. It's yes. Everybody's paying attention. Now, let's say that you had a multiple myeloma where the cells don't look too much like plasma cells. They would probably express less monoclonal gamma protein and light chains, wouldn't they? And furthermore, what do you think is worse? A multiple myeloma where all the cells look like classical plasma cells, or a multiple myeloma where most of the cells do not look like classical plasma cells? Okay, somebody asked a question about Waldenstrom. We'll get into that later. Now, the next thing I want you to do, I'm not going to ask you to stand up, but I'm going to tell you the 3 or 4 things you need classically to absolutely identify a plasma cell. Every plasma cell has a round nucleus, but the cytoplasm is oval. So the nucleus is usually off to the side. Now, usually between that nucleus and the wider part of the cytoplasm, there's a clear zone. That's the Golgi apparatus. That's where the antibodies are being stored in those big vesicles. That's the second thing. And the third thing, which you could see better here on electron microscope, but you can also see here, is that they have what they call the cartwheel or clock face nucleus, where most of the denser chromatin is distributed towards the periphery of the nucleus. Now, if you look at pictures of lymphocytes, that's also true with lymphocytes as well, but it's even more true with plasma cells. So here are the 3 things. Oval cytoplasm with a round nucleus off to the side, a cartwheel or clockface chromatin in that prominent clear zone. Sometimes it's called a Hoff. It's definitely a Golgi. There's other names for it. Sometimes when they're prominent, they call them Russell bodies when there's a lot of them. Those are the 3 things. If you have these 3 things in a cell, and here's the most classical looking plasma cell right here. If you see a cell that has these 3 features, it is a plasma cell. It can't be anything else. If it has only 2 of the features, excuse me, it still might be a plasma cell. And of course, this is expressing monoclonal gamma protein, okay, gamma G, maybe gamma A as less likely. If it's gamma M, that's usually called something else. So in your normal serum protein electrophoresis, the biggest peak is on the left, that's your albumin. Then you have your acute phase reactions, alpha 1 and alpha 2. Then you have your beta fraction of beta proteins. Then you have this wide gamma, which is usually about the second biggest thing. But it's not a spike, it's a gradual hill. When it's a monoclonal, not only is it a spike, but it's very often about the same amount quantitatively as the albumin. So, I use the term Batman sign, or I don't know if you know that there's a certain expression where you could hold up your first and your fifth finger, and that's called the BS sign. But in it, this is a classical serum protein electrophoresis for somebody with a monoclonal gammopathy. A lot of gamma monoclonal protein and almost as big as the albumin. The primary place for multiple myeloma is in the marrow. Sometimes they can spill out a few cells into the peripheral smear. It's also associated with fairly predictable deletions and translocations. I think it's sadistically cruel to try to ask you to memorize them because I don't want to memorize them. Normally, the amount of plasma cells in normal marrow is just a couple percent. But if it ever goes over 20%, if you like to count cells, then that's probably a multiple myeloma. So if it's, let's say, between 3 and 15 or something, it could be a multiple myeloma, but it also could just be a benign reactive condition of plasma cells. Also, even if you see less than 20% plasma cells, but they're in sheets in certain areas where 100% of all the cells are plasma cells in a certain area, that's also very, very likely to be a multiple myeloma. The plasma cells usually look normal, thank God, because if they didn't, you'd wonder what they were. And most of the myelomas have the expression of gamma G. Gamma A is possible. It's a lot rarer than gamma G. And if it's gamma M, you normally don't call that myeloma. You call it Waldenstrom's, but we'll deal with that later. People with multiple myeloma, they have bleeding because this massively increased amount of gamma globulin usually interferes with normal coagulation. And of course, buildup of immune protein, like monoclonal protein, is amyloidosis. So they get amyloidosis much more likely than just normal older people. And the monoclonal protein just loves to go to the kidneys. We saw the light chains called Benzone protein. They like to destroy the kidneys as well. So many of them are at risk for renal failure as well. Here is the classical. If you ever get a picture of a skull on a board question, I can tell you this from experience, it's probably going to be a multiple myeloma. See these little holes or lucencies in the calvarium? Those are called punched out or lytic lesion. Punched out is the buzzword that they use. So that's a classical thing for a myeloma skull. And why is it punched out? Because that bone area is now bone marrow, which is a lot less dense. And if you look at that bone marrow, there's a very good chance it'll be predominantly plasma cells. We're right at the ending point, but I got two more quick things to show you. No, we'll stop here. We'll call it a day because there's a couple of other things that's going to take more than a minute. We're done with today. Thanks for coming around and had another great time. You know, the chapter on WBCs is just wonderful. When I review these things the previous day, I look for bumps. I look for things that aren't smooth, and I try to iron them out, maybe make them better than the previous year. This is a very smooth chapter. It's a logical chapter. It's a graphic chapter. And it's enjoyable for me as well. So I know it's enjoyable for you, but I know you're going to tell me you liked it anyway. So let's close off our session today with the third and final Doors song. It's a fun, fast song. Usually we close things off with slow, philosophical, love, deeply profound songs. This is going to be a fun Doors song. It's called Love Me 2 Times, and I'll see you in 2 days, buzzards.
Love me 2 times, baby. Love me twice today. Love me 2 times, girl. I'm going away. Love me two-time girl. One for tomorrow, one just for today. Love me two-time, I've gone away. Love me one time, could not speak. Love me one time, yeah, my knees got weak. Love me two-time girl, love me all through the week. Love me two-time, I've gone away. Love me two-time, I've gone away. Ah, yeah! Love me one time, could not speak. Love me one time, baby. Yeah, my knees got weak. Love me two-time, girl. Love me all through the week. Love me two-time, I'm gone away. Love me two-time, baby. Love me twice today. Love me two-time, baby. 'Cause I'm gone away. Love me two-time, girl. One for tomorrow, one kiss for today. Love me two-time, I'm gone away. Love me two-time, I'm gone away. Love me two-time, son, gone away.
From Jim Morrison and Dr. Minarcik, rock on, you buzzards.
The organ.